Yeah, okay, great. So serum protein electrophoresis is not very different. I mean, the principle remains is basically the principle remains the same, whatever you do, be it serum protein electrophoresis or hemoglobin electrophoresis or DNA electrophoresis. Basically, polar or charged molecules are made to migrate under the influence of an electric field, and there is a medium. So the medium can be gel, cellulose acetate. Gel can also be of various types. It can be agarose gel. It can be SDS polyacrylamide gel. So all these things are different types of electrophoresis, right? So when we do serum protein electrophoresis, as the name suggests, we are separating different, I mean, all the proteins which are there in the serum, the big, into different compartments. So you realize that protein is one of the most, I mean, concentration wise, it is one of the highest concentration of things that are circulating in our blood, right? If you see the normal ranges, the total protein normal range is in grams per deciliter. Whereas other stuff like glucose, creatinine, urea, they're all mostly in milligrams per deciliter. You can imagine grams per deciliter versus milligram per deciliter. कितना ज़्यादा protein है. Of course, amongst all the proteins, the commonest one is albumin. So broadly, you can divide proteins as albumin and globin. Now, this picture here shows you how a typical setup looks like. There are electrodes. You have a positive electrode and a negative electrode, which is connected, which generates the electric field. Then there is a liquid or buffer that is there, and then you have the gel, which is connected with a wick, which may be a cloth or tissue or Wattman's filter paper, whatever you put. Then there are different compartments or wells which are created in the gel, in which you put the samples of interest. When the power is switched on, there is an electric field generated between the two electrodes, and current flows in one direction. When there is electric field that is being generated, there are two, three things we need to be careful about. You have you have to see to it that the gel doesn't dry up, because whenever there is electric current flowing, it is going to generate heat. So one of the things is it should not dry up completely. Then the migration would not be proper. Then secondly, the buffer that you're making. Uh, so commonly we use a barbitone buffer which has a alkaline pH, mostly around 8.4, 8.6. So why is it important is when you're talking of proteins, you have to just think about proteins as zwitterions. So zwitterions, I mean, amino acids are zwitterions. So proteins also tend to have both kinds of charges, right? So depending on the side chains and the groups that are available to interact with it, with its surroundings. So the pH of the buffer plays an important role, because if the pH of the buffer is more alkaline compared to the isoelectric point of that protein, the protein is going to basically develop a more negative charge, and it will go towards the positive electrode. Whereas if it is less than the isoelectric point, then it will develop a positive charge and it moves towards the negative electrode. So the positive electrode is also known as anode, and the negative electrode is known as cathode. So positive ions which are going towards the negative electrodes are uh, the cations going towards the cathode, and the negative ions which are going towards the positive electrodes are known as anions. So we are all clear of this, right? So if you want to remember, the anions are negatively charged, N for negative, N for anions. Okay. So moving ahead, yeah. So you can have different sizes, dimension. You need a power supply which gives you a direct current. You need a chamber where the electrophoresis is going to happen, and you need the applicators. So there is a constant current which is given of around 70 to 100 volts. Separation time depends on the distance, but mostly 30 minutes, 1 hour, 2 hours, depend how big the gel is. Electrophoresis in supporting medium is then done. Fixation. After that, you fix, stain, destain. These are different steps that are there when they're done manually. Now, You have to understand that electrophoresis is mostly a qualitative test. At best, you can call it a semi-quantitative one, right? Because there's a bit of subjectivity which is there. It is easy, it is inexpensive method for separating proteins. Broadly, there are two major types of proteins in our blood, that is albumin and globulin in serum. Albumin is the major component under normal circumstances. In various disease states, of course, the albumin component goes down and globulin component increases. So other things, you have fibrinogen and then different types of globulins you have. They are separated, I mean, depending on their separation, they are divided as into different compartments as alpha globulin, beta globulin, and gamma. Alpha is again further subdivided as alpha 1 and alpha 2. Beta can also be subdivided as beta 1 and beta 2. And then you have gamma, right? So when you think of serum protein electrophoresis, we use it. Why? I mean, we use it regularly in our lab because we do it for screening and monitoring for myeloma or plasma cell dyscrasia. Not just myeloma, various lymphomas and plasma cell dyscrasia. They are monitored. Their stage, their treatment, everything is monitored with the help of SPE, IFE, and quantification of immunoglobulins. So we not only do serum protein electrophoresis for the myeloma panel, we also actually measure what are the concentration of different immunoglobulins that are there. And we do it by a technique which is nephrometry based or immunoturbidimetry based. Then you have another kind of test which we do, that is the number 3, which is immunofixation electrophoresis. So why are we doing two kinds of electrophoresis? The first one we are doing is called screening of electrophoresis. Whereas the third one is immunofixation is a confirmatory test. The first 3 tests that you see are mainly done on serum or plasma, mainly done in serum. You can also do the similar things on urine also. And then free light chain assay again can be done both in serum as well as in urine. So why we do all this is mainly to identify if there is a clonal proliferation of plasma cells which are secreting in extremely high amounts a specific clone. When we are talking of clones, these are clones of antibodies, right? And you know that plasma cells are the cells which secrete antibodies. So when you antibodies are also known as immunoglobulins, right? Broadly, there are 5 different types of heavy chains and 2 types of light chains in the immunoglobulin. We'll see that structure later. When you talk of serum protein electrophoresis as a method, as a technique, we are able to separate our serum into these 5 components, 5 or 6 components, depending on what you're using as for electrophoresis. So if you're using a gel-based method or cellulose acetate method, you may get 5 zones. Whereas if you're using a capillary-based separation method, capillary electrophoresis, then you may get 6 zones. The difference being, when you're doing gel, the beta 1 and beta 2 often are not very far off from each other. They cluster together and you have a single beta fraction. Whereas when you do it in capillary, these 2 fractions can be resolved into 2 separate peaks. That's the main difference. So here you can see this image, major components of globulin. So the darkest one, the most highest concentration of all the proteins is albumin, followed by, in terms of their separation, you can see they are labeled as alpha 1 globulin, alpha 2 globulin, beta 1, beta 2, and then gamma. And you can see in these different fractions, in alpha 1 you have alpha 1 antitrypsin, in alpha 2 you have haptoglobulin, alpha 2 macroglobulin, HDLs, they migrate in the alpha 2 fraction. In beta 1 you have beta 1 and beta 2 you have LDL, complement, C3, transferrin, and so on. And all the immunoglobulins mostly migrate in the gamma region, and along with fibrinogen, which may be in the beta or gamma region, right? This is what it looks on the gel. You may measure its density with the help of a scanner or a densitometer, and you can get these kind of peaks. So that is why you can call it semi-quantitative. If you know the total protein concentration, then each fraction can be quantified. Right now, here, this is one of the instruments that we have in our lab. It's a capillary-based electrophoretic apparatus. So this is a very thin silica capillary, which the migration happens. The buffer is there. The instrument takes up a very small amount of the sample and it is migrated. There is no staining, destaining per se over here. As as the proteins separate and reach the detector, there's a detector here, crosses the detector, there is a change in absorbance because of the proteins. And based on this change in absorbance, there is a peak which is generated. So if you see here, the first anion of the albumin is the protein which migrates most to the maximally towards the anode. Yeah. Whereas the gamma globulins is mostly stationary near the point of application. And in between you have alpha globulins, beta globulins, and so on. So this is basically the similar image which is showing you different fractions. You have albumin, alpha 1, alpha 2, beta, and gamma. This is how a typical gel would look like. It's not very sharp and clear, but there are clustering and more than one protein in one of these fractions, right? This is what a proper slide gel electrophoresis, actual slide gel looks like. If you look closely, you can see a faint band here. This is the point of application. So this is albumin. You have alpha 1, alpha 2 is this dark section. This is the beta, and then gamma. So this is the image of a normal serum protein electrophoresis with a barbitone buffer on agarose gel, slide gel electrophoresis. Right. So albumin is near the anode, and towards the cathode, you have the immunoglobulins or the gamma globulins. This image, again, if you see, you can see two bands. It looks similar. How do you know which is which? You can see this line where there's a cut in the gel. This is the point of application. So if there is a band near it, that means it is a gamma globulin. Whereas the one farther away from it is albumin. So you have albumin and immunoglobulin. There's an M band. So it is called an M band because it's a monoclonal band. It's a band due to monoclonal immunoglobulins or proteins. Right. If you want, you can quantify this with the help of a scanner and densitometer. These are different types of commonly used electrophoresis. I am trying to, this image basically highlights why you have different kinds and what are the pros and cons of different kinds of electrophoresis. So you have the first one on the left, cellulose acetate electrophoresis, agarose gel electrophoresis, and capillary zone electrophoresis. If you notice the direction, I mean the albumin is denoted towards the left in capillary, in cellulose acetate and agarose gel, whereas it is towards the right in capillary zone. That is because it is the last to come out from the capillary while it is detected. So that's a reversal. Now, is that the only difference? One more difference is you will see that, okay, in the first image, across all the three kinds of electrophoresis, it is similar. You can see a peak for albumin, alpha 1, alpha 2, alpha 1, alpha 2, beta, and gamma. Again, in agarose gel, it's same, albumin, alpha 1, alpha 2, beta, and gamma. Here, albumin, alpha 1, alpha 2, beta, beta 1, beta 2. You can see two fractions of beta. So this single fraction has become two fractions here, and then there's a gamma fraction. So if the proteins are normal, there's no problem. If there is a big monoclonal M band, there's no problem. Like in the second image, you can see a M band, right? So this is albumin and this is the peak, the monoclonal band over here, M band. Can be seen in cellulose acetate, can be seen in agarose gel, can also be seen in the capillary zone electrophoresis, right? But here there is also another peak which is there. So there may be the heavy chains and light chains of immunoglobulins which are separated. Problem arises in these kind of cases. In the C row, you will see that in capillary, in cellulose acetate and agarose gel, it looks pretty much that there is no monoclonal band, and it looks like it's normal, right? So you have albumin, alpha 1 fraction here, alpha 2, beta, and then gamma. Gamma is not exactly normal like this, but there is some abnormality, but doesn't seem to be having a monoclonal component. In agarose gel, again, there is a slight bump that you see here with this arrowhead, but it's not very obvious. The same thing when you look at with capillary zone electrophoresis, it looks like there is a sharper peak over here. And that is why capillary electrophoresis is much more sensitive than agarose and cellulose acetate, right? So we use capillary electrophoresis routinely in our lab. Then when you're doing electrophoresis, different fractions have different normal ranges, reference ranges that you can get. Right? There's not too much over there. And different fractions can be increased or decreased based on the situation. Like in dehydration, you may have an increased albumin. In malnutrition, cachexia, burns, you may have a decreased albumin fraction. Alpha 1 may go up in pregnancy, in inflammatory states. It may decrease in alpha 1 antitrypsin deficiency. Similarly, for alpha 2 fraction is significantly high in nephrotic syndrome. Uh, it may be decreased in hemolysis, liver disease, and so on. The beta fraction may increase in iron deficiency anemia because of transferrin and those things. It may reduce with malnutrition and hypo B lipoproteinemia. Gamma fraction can increase with monoclonal gammopathies, or if there is a overall increase across all types of immunoglobulins, which is also known as polyclonal rise. Similarly, it can go down with treatment when there is hypogammaglobulinemia or agammaglobulinemia. This is what your typical immunoglobulin molecule looks like. There is a heavy chain and there are light chains. You have a pair of heavy chains and a pair of light chains. Heavy chains are further subdivided as G, A, M, P, or E. So, whereas light chain are also known as kappa and lambda. So, G, A, M, P, or E also stand for gamma, alpha, mu, delta, and epsilon. Immunoglobulin structures, basically you can see that IgM is more polymeric, IgA is often dimeric, whereas IgG and D are simple Y-shaped molecules that you like to see. Individually, if you look at different fractions, there will be conditions. Some would be benign, some would be pathological, where you can see a different kind of pattern than you would normally see, right? So you have something known as dysalbuminemia, where you have two peaks of albumin in this image, right? Alpha zone, again alpha 1 antitrypsin related diseases, thyroid binding globulin, alpha 2 fraction where there is disease involving ceruloplasmin, haptoglobin there is, hemolysis, intravascular hemolysis, these things will be affected. Many of them are acute phase reactants. Many acute phase reactants travel in these fractions in the beta and alpha fraction. So you can see differences or deviations from normal patterns when these kind of diseases are also there. It is not that you will see an abnormal pattern only when there is a myeloma, but you can also see abnormal patterns in various other conditions, right? Iron deficiency anemia, pregnancy, estrogen therapy, and so on. So you can have a look at these in detail. Again, gamma zone, it is not just the monoclonal component, various inflammatory conditions, chronic inflammation, you may see there is a bridge or there isn't a dip after the beta region. You may have a beta gamma beta bridging, which is there. So these kind of things are commonly observed when serum protein electrophoresis is done. This is what gel normally looks like. There are multiple wells. In each well, a different sample is analyzed and run. Here, these slides now are going to show you different conditions where and common reasons where you can have these kind of patterns. So if there is a loss of albumin through the kidney or GI, or there's a liver disease, less synthesis of albumin, malnutrition, hemodilution, you can see that when you compare the albumin, it is less dense as compared to the other levels of albumin. So you have hypoalbumin in decreased alpha 1 in this one. You can see when you compare it to the others, the alpha 1 fraction has gone down, maybe due to alpha 1 antitrypsin deficiency, liver disease, protein loss, and so on. Similarly, increased alpha 2 region, maybe due to hemolysis. There may be light chain disease and monoclonal proteins which are there, or it may simply be an acute phase reaction which has led to increase in alpha 2 fraction. Similarly, increase in the beta 1 region over here. As compared to the other ones, you can see that beta 1 has increased, maybe due to increase in transferrin in iron deficiency anemia. So, how do you confirm? If you do a immunofixation electrophoresis, you will not see a monoclonal band, because the immunofixation electrophoresis basically shows you a band if there is a immunoglobulin monoclonal component of immunoglobulin band. We will see those also. Beta gamma bridging, when there's a, you cannot separate the beta from the gamma region like this. It just goes into or eases into the gamma section. So if there is commonly associated with liver cirrhosis, chronic inflammatory diseases, some malignancies, but not necessarily myeloma. Non-myeloma other malignancies can show you these kind of patterns. Acute inflammation, you will observe increase in alpha 1 and alpha 2 globulin fractions, may be associated with infection, injury, trauma, right? In lane 2 and lane 12, and see the alpha 2 is significantly increased, right? Chronic inflammation, again, you can see that alpha 2 is increased. There's also a decrease in albumin, autoimmune diseases, chronic liver diseases, and so on. Cirrhosis causes changes where you can see albumin has gone down, beta fraction goes up, gamma fraction may also go up, and you may have a beta gamma bridge. Kidney damage, mostly associated with alpha 2, increase significant rise in alpha 2 and beta fractions. So you can see the alpha 2 is looking much more thicker and dense, commonly seen in nephrotic syndrome, right? There may be a decrease in albumin because there is protein loss happening through the kidneys. Hypogammaglobulinemia, sometimes you can see this part is very clear, there's nothing there. So when you actually measure the concentrations of immunoglobulin, they will be very less. So this may be seen with multiple myeloma, amyloidosis, lymphoma, and so on. Polyclonal gammopathy, basically associated with infections, chronic inflammatory conditions, autoimmune conditions, and those kind of things may show you polyclonal gammopathy, right? You can confirm it with immunofixation electrophoresis, and you will not see any monoclonal components over there. So when you measure or quantify the immunoglobulins, you will realize that all the immunoglobulins have, or more than one immunoglobulin fraction has increased in its levels. Polyclonal gammopathy, yeah. So again, gamma globulins are raised, albumin has gone down, associated liver disease, and so on. So this table basically highlights the causes where you can see a polyclonal gammopathy kind of picture. You have liver disease, connective tissue disorders, infections, various malignancies of hematolymphoid system, non-hematological malignancies, other malignancies, right? So monoclonal gammopathy basically will present like a sharp peak. How big the peak is depends on the concentration of the monoclonal band. So these images that you see in the rectangles are all M bands over here, M band here, M band here. Sometimes you may have two fractions, maybe a biclonal gammopathy, right? And most of them, though they are in the gamma region, sometimes they may also migrate in the beta region, the monoclonal ones. So it is not that you will not get an M band in the beta region. You can get a M band in any region, but majorly it is seen in the gamma fraction. Generally, so SP, when do we do it? When there is elevation of total protein or there is a reversal of AG ratio, and there's a high index of suspicion for plasma cell dyscrasia, you would do a serum protein electrophoresis to screen for plasma cell dyscrasia, amyloidosis, and Waldenstrom. All these things involve the plasma cells, right? Symptomatically, there would be anemia, back pain, bone pain, fatigue, pathological fractures, hypergammaglobulinemia may be there. So all these things are often one of these things are often the presenting complaints of these kinds of patients. M band in beta region in the picture over here. So gamma, there's nothing there, but there's a big peak in the beta region. M band here you can see is in the gamma fraction. So now we can quickly see various patterns. You see here there are two peaks in the alpha 1, which is suggestive of heterozygous alpha 1 antitrypsin. Here, the alpha 1 antitrypsin has gone down. The gamma fraction total concentration seems to be up. It is polyclonal, so it's a hyper gamma globulin region where all the immunoglobulins have increased. There may be a suspicious peak, which is if you do SP on a hemolyzed sample, this is what you will get because you get a peak of 5 nanogen, which you can confirm with immunofixation. So you will not get a monoclonal band here. Nephrotic syndrome, alpha 2 is significantly raised. M band with a polyclonal background, hypogamma-globulin region, there's suppression of the gamma fraction. Acute inflammatory response, again, similar to nephrotic, you have increase in alpha 2 and beta. Sometimes you get two peaks, and they may be due to biclonal bands, which again need to be quantified or confirmed with a immunofixation electrophoresis. What is immunofixation electrophoresis? It is again a special type of electrophoresis, only difference being you're adding anti-sera against the immunoglobulins. So you have anti-IgG, anti-sera, anti-IgA, anti-sera, anti-IgM, anti-kappa, anti-lambda. We don't routinely use anti-sera against IgD and IgE because monoclonal bands of IgD and IgE are very rare. Right. So this is basically image of the instrument that we use to do immunofixation electrophoresis. You get ready-made gels. You don't have to make your own gel, and as you do in your experiments and practicals, here you have a gel which is already there, and it is made to run under the electric field. Yeah. So this is what your typical gel looks like. You have a column where it is like your serum protein electrophoresis, SPE. So they have written ELP for it's like a complete serum protein electrophoresis. Then you have different lanes named as G, A, M, K, and L for IgG, IgA, IgM, kappa, and lambda. And in these individual lanes, you are going to apply specific anti-sera against these immunoglobulins. So if the monoclonal band is there, you will see a band here like this. And you want to know is the immunoglobulin or what is the clone or what is the type of immunoglobulin which is involved. So you do immunofixation in electrophoresis, and with this you realize, okay, like in this image, it is of IgG and lambda type, right? IgG and lambda I gave. Here it's IgG and kappa. Here you have multiple bands. You have IgG, kappa, and IgA, lambda. You have IgA, kappa here. You have IgG and kappa, IgG and lambda, IgM and kappa here. Here again, you have IgG and lambda and another component, mostly a free component of the immunoglobulin. The free light chains sometimes are synthesized in uh, more numbers as compared to the heavy chains. And they are, so when there's a mismatch, because it's a cancer, they're proliferating indiscriminately, they're synthesizing immunoglobulins without a plan, and it's not synchronous. You'll realize that there is excessive light chains or free light chains, which is not bound to the heavy chains. So in this case, you can see that there's a different band which you can see for lambda. There is no heavy chain corresponding to it, but below that you have a IgG and lambda. So essentially, it's a IgG lambda with excessive free light chain formation, right? Procedure wise, you can go through this if you want. So there is sample application, it takes 1 minute, and then there's migration under the electrophoretic field, anti-sera is applied in different lanes. It's color coded for easier identification, what is what. Then the excess, the immune complexes are precipitated, the excess is then blotted and removed, the excess anti-sera is removed, the gel is dried, then there is the same things like you do in your experiments, there's washing, staining, destaining, and finally the gel is dried and you look at it and you interpret. So the good thing is it can detect lower concentrations of monoclonal bands also, the least being up to 125 milligrams per liter, which also translates to 12.5 milligrams per deciliter, depending on how much background noise is there. This is what it looks like. This is known as a mask. There are different wells where you can put the specific anti-sera. So this image shows you how it normally looks. These are polyclonal immunoglobulins, and you have a spread out uh, kind of shape of the gamma fraction here. But if it's a monoclonal, they all stack up and you get a peak kind of appearance. So there's a small animation here. It shows you all the immunoglobulins are there. Anti-IgG, anti-sera is added, and then the excess is removed. And finally, after staining and de-staining, you can see a specific monoclonal band in the gel, which is of IgG type, right? So this is called the immunofixation electrophoresis, right? So this IgG is this dark area in the middle, whereas you have a polyclonal background or shoulder kind of effect that you see in gel, right? So you have a focused band in IgG and in lambda, and you have immunoglobulin background. What that means is if you measure the different immunoglobulins, it is not that you will only measure IgG. The other immunoglobulins also may be in a higher or normal concentration and they are not suppressed. So here this is a normal serum with polyclonal immunoglobulins, right? Polyclonal, everything is there. There's no band. It's like a zone. It's hazy, isn't it? This is what a normal IFE and normal serum protein electrophoresis would look like. And then you have IgM lambda, bands in IgM and lambda, IgG and kappa. There's a faint band here. This is very faint, right? There are challenges. Sometimes it is difficult to see. It's subjective. One person may feel there's a band, another person may feel there's no band. Especially if the band is faint or transient or barely visible. So suppose if a person has an infection, you may see some transient bands because antibodies directed against bacteria may be being generated in the body. Solutions, you have to treat all your patients with a high index of suspicion. You have to correlate with the symptoms, correlate with imaging, bone marrow, and also quantification. So you're not just doing serum protein electrophoresis, you're doing SPE as a screening test, you're confirming with IFE, you're measuring the free light chain components, you're quantifying the immunoglobulins, and also looking at the bone marrow. Different patterns you can see here, IgG and kappa and IgM and kappa. So it's a biclonal pattern on SPE. On IFE you can see two bands, right? There are two bands over here, IgG kappa and IgM kappa. It's a biclonal profile. Sometimes you get these kind of patterns, especially the cryoglobulins. You know, cryoglobulins tend to precipitate at colder temperatures, or if it's a polymerized IgM, so it migrates, it basically sticks with the anti-sera in all the different lanes, but it's not a monoclonal pattern. I know it's a bit confusing, but it's not monoclonal. Sometimes you may have a light chain disease where only a light band is seen in the light chain, but there's no corresponding band with the heavy chains. Yeah, IgG lambda, IgM kappa, and IgG kappa. So now these are certain cases that we come across which are a bit interesting even for us. So you can see there is a monoclonal band here in beta fraction. Concentration is about 1.8 grams. And when you do the immunofixation, we realize that there are probably two peaks, one IgM kappa here and one IgM lambda fraction over here, which one would have missed if you're not alert. Now, this is a case of a sudden appearance of a new additional monoclonal band. Patient basically presented with sudden onset lower back pain, everything else is normal, nothing specific. At admission, these were the values. Hemoglobin, you can see there's anemia, there's total protein which is increased, albumin is less, reversal of AG ratio, creatinine is on the higher side, calcium surprisingly has gone down, beta 2 microglobulin is raised, other things like ferritin and LDH are also elevated. With myeloma, you have something known as CRAB criteria, where you have hypercalcemia, anemia, renal problems like creatinine is elevated, and bone lesions, right? But not all of them are always going to be positive. On bone marrow, what we found was there were 31% plasma cells, and they did a immunophenotyping of the different kinds of immune cells in the bone marrow, and they saw that it was bright or reactive with the CD38 and positive for lambda. Okay, so July 2019, these were the levels. You can see IgG is significantly raised, 7,000, normal is up to 1,500. Lambda is also raised, 3,600 milligrams per deciliter, normal is up to 700. Then the ratio of involved and uninvolved free light chain. So free lambda is also elevated over here, right? Free kappa is not so much. So all these things are showing that there's a monoclonal band. So there's no confusion there. M band concentration was 5.6 grams per deciliter. Subsequently, treatment was started, patient was being monitored, the concentration of M band reduced. Other parameters also went down, patient was improving. In November 2019, again, M band has gone down from 5 grams to 1 gram. September 2020, surprisingly, M band concentration was found to be increased. This is COVID time, probably less frequent follow-ups, less stringent monitoring. Things seems the myeloma has relapsed. Finally, in November 2020, again, it has gone down. So what happened in 2019? We had a immunoglobulin, I mean the M band concentration of 1.1 in the gamma fraction. On IFE, you had IgG and lambda, right? No confusion, pretty straightforward. This is the monoclonal band that you see. Yeah. The other fractions, this is albumin, alpha 1 is suppressed, alpha 2, beta 1, and beta 2. Other investigations which were done, and there was cytogenetics which showed that the prognosis, I mean, was more or less an aggressive kind of myeloma that we're dealing with. Treatment, standard lines of treatment were started with lenalidomide, bortezomib, dexamethasone, and achieved very good partial response, which is VGPR. 12 cycles, I mean, of VRD were given till June, and on bortezomib maintenance. Patient was on bortezomib maintenance. Patient started worsening with low back pain and occasional hip pain in June 2020. And in November 2020, the M band again 1.1 in beta, but there's something else. Like there are two bands now. You have one band of 1.1 grams or 1,100 milligrams, and you have a 100 mg per dl small band at the gamma fraction. So we did the immunofixation. What did we find? We found IgG lambda as we saw initially. It's still there, but below that you can see you have IgG and kappa. There is another line, another band here, IgG and kappa. So we thought, what happened? Has it suddenly become biclonal or monoclonal? What is happening? Is it IgG lambda and IgG kappa? So we realized and we looked at the medical records and found that this is probably not a endogenous M band. It is a iatrogenic band that was being given. So in different cancers, you have heard of probably immunotherapy and monoclonal antibodies being used. So the clinicians were using a drug known as daratumumab or Darzalex, which is a IgG kappa kind of monoclonal antibody directed against CD38, which was overexpressed in this patient, and it is overexpressed in various multiple myeloma cells. So daratumumab binds to CD38 and induces apoptosis of these myeloma cells. So not all bands are endogenous. It can be also because of the treatment. And the second case is also interesting. Here you had a 61-year-old male smoker, known case of adenocarcinoma of left lung. On pembrolizumab and carboplatin, received chemotherapy, radiotherapy, everything is going on. And suddenly we got an interference in our routine biochemistry. Over here, what we see is direct bilirubin is negative. I mean, mathematically it can be negative, but biologically it's difficult to explain why a direct bilirubin should be negative, right? So whenever you see something, you have to suspect some kind of interference. And in this case, this was a case of lung cancer, adenocarcinoma of the lung. But what are the common causes of interference in biochemistry? They are hemolysis, icterus, lipemia. But there's also a fourth one, that is paraproteins. We suspected it to be due to paraproteins, and we did a reflex serum protein electrophoresis, and this is what we got. We got a monoclonal band which is around at least a gram or so. And when we did the immunofixation electrophoresis, it was of IgM kappa. So IgM kappa monoclonal band was there. So this patient, along with being a case of adenocarcinoma lung, also had either a secondary myeloma or a synchronous myeloma, which also needed to be treated. So this is how our clinicians entered in their medical records, and subsequently myeloma treatment was also started for the same patient. Case 3, here you can see values, immunoglobulin levels. IgA is less than the normal, it's suppressed. IgM less than the normal, suppressed. IgG more or less on the lower side. Pre kappa, pre lambda again suppressed. Everything looks less. Total lambda and total kappa is normal, and total lambda is suppressed, right? And when you did a serum protein electrophoresis, you have a small band of 400 mg per dl. Why this is important is because the IMWG emphasizes on the free light chain ratios being abnormal, but in this case you can see the free light chain ratio is not very abnormal, whereas the total light chain, that is total kappa and total lambda, the ratio is deviated from the normal. And there is immunosuppression in all the unaffected chains, IgA, IgM, they are suppressed. So here you can see that. So this is also known as immunoparesis. So whenever myeloma develops, you will see that the clone proliferates, but it suppresses all the other immunoglobulins. So you can have lower levels of other immunoglobulins, right? And you have IgG and kappa. So IgG is not suppressed; it's in the normal range. Kappa is again in the normal range. Everything else is suppressed. So the take-home message with when you're doing SPP and reporting for myeloma, like after you pass and you go ahead to report, you have to keep certain things in mind. You do the serum protein electrophoresis, you quantify immunoglobulins, you measure the light chain assay, and you confirm it with immunofixation electrophoresis. Just doing one thing over the other is not going to help. Just a second. Yeah. So the monoclonal band can migrate anywhere between the alpha to the gamma regions. You have to be aware and alert. Is it a monoclonal band that you're seeing, or is it some kind of interference or false positive band that you're dealing with? New things will keep on coming, newer interferences will keep on happening. So you have to be a smart and intelligent biochemist and look at the report in totality, and not just, okay, I've done SP and in SP I'm seeing something wrong, so it's a M band. With this, I'll end the talk and be happy to take any questions.